Good morning. My name is Nichole Starr. I'm a general surgery resident at UCSF, and today I'll be presenting our work on lasting improvements of a surgical infection prevention program, a sustainability audit of clean cut in Ethiopia. Thank you for your time today. Surgical site infections are responsible for significant morbidity and mortality in low and middle income countries. Recently, a number of multimodal infection prevention and control programs have been implemented in low income countries with subsequent reduction in surgical site infections. The Clean Cut program is one such adaptive, multimodal 6-month quality improvement program that we piloted in Ethiopia. High compliance with perioperative infection prevention practices resulted in a 46% relative risk reduction for surgical infections. However, the persistence of practice changes after QI interventions is rarely assessed, and it is unclear whether many surgical IPC programs in LMICs provide short-term solutions only or result in long-term cultural and behavioral shifts. We aim to measure the sustainability of improvements made in infection prevention practices following the Clean Cut program. 8 hospitals in Ethiopia completed the program between 2015 and 2019. Through surveillance of infection prevention practices, process mapping, training, and action planning, surgical teams improved behaviors in 6 key areas of infection prevention: surgical safety checklist use, skin antisepsis, antibiotic prophylaxis, surgical linen sterility and integrity, instrument sterility, and gauze counting. Between 6 and 18 months after completion of the program, we conducted a 14-day assessment of perioperative practices via direct observation. 7 hospitals were included in the sustainability assessment. The 8th facility had transitioned location and leadership and could not be reached to participate. Data collectors observed all operations during a 14-day period using the same Clean Cut data collection tool. Ethical approval was obtained. Data analysis was performed using STATA. Compliance was defined as correctly performing 100% of expected behaviors in each of the 6 key areas. The study cohort included 738 patients in the pre-implementation period, 2,178 in the post-implementation period, and 469 in the sustainability audit. The case mix was similar between groups. The sustainability group had slightly fewer comorbidities and included more obstetric and surgical specialty procedures. Relative to the post-implementation period, the sustainability audit period showed further improvement in compliance with the surgical safety checklist used from 50 to 58%, skin antisepsis from 58 to 75%, antibiotic prophylaxis from 59 to 66%, and gauze counting from 94 to 95%. There was some attrition in compliance with surgical linen integrity and sterility from 46 to 39% and instrument sterility from 55 to 42%. But performance in these areas remained far above baseline. When performance was measured over more granular time periods, many areas saw peak performance in the final third of program implementation and some drop off by the sustainability evaluation, though antibiotic administration and gauze counting continued on an upward trajectory. This evaluation demonstrates that behavior changes made as part of this multimodal surgical quality improvement program are persistent and in some cases continue to improve. This study has some limitations as there are other initiatives focused on surgical infection prevention and quality improvement in Ethiopia that may have supported the persistent improvement in practices at the 7 hospitals. Furthermore, the proper assurance of surgical linen and instrument sterility require the availability of sterility indicators and functioning autoclaves, which rely on biomedical engineering expertise and purchasing decisions at the management level. These elements are not always under the control of surgical teams, however cohesive the operating room environment. Despite demonstrable improvement in practices and infectious complications across surgical quality improvement programs, the long-term successes of most interventions is not measured. This assessment is further evidence that interventions to improve surgical quality and infection prevention behaviors are worthwhile investments that will continue to provide improved patient safety in the long term. Thank you to my team, including Jared Forrester and Tom Weiser, my mentor, and thank you to the Stanford Resident Research Day for the opportunity to present our work. I'll be happy to take any questions.